Aishwarya, you can start.
Okay, Ma.
Okay. Good evening, everybody. Welcome to the monthly academic series, monthly CME, an initiative of AFPI Kerala North Zone. I invite Dr. Prashop, President, AFPI Kerala North Zone, to give the welcome address.
Hi, good evening all. I'm Dr. Prashovan, AFPA North Zone President. It is always important to know how to treat and how to evaluate a case of non-alcoholic liver disease. It's an important topic for PG students during examination as well as practicing clinicians. So today we have Dr. Bonnie George. He's consultant gastroenterologist at Todupuzha. He did MBBS from Pariyara Medical College, MD from Pune, and DM from Trivandrum Medical College. This session is moderated by Robi. She's consultant family physician at Robi's Medical Center, Calicut. On behalf of AFPA North Zone, I welcome all of you for this wonderful session. Without delay, we can start. So Aishwarya, you carry on.
Hello, is Dr. Robi? Ma'am, are you there?
Yeah. Yes, Aishwarya.
Ma'am, I
Right.
invite, you are the moderator. Dr. Robi is the moderator of the session. I invite Madam.
Yeah, as Prashop said, this is a very important topic for all of us because we see a lot of cases of non-alcoholic fatty liver disease, and people are more concerned about their fatty liver nowadays. They come to us with a USG report showing fatty liver and ask about the possibilities of future diseases and complications and everything. So I think this is an important topic. As Prashop has introduced Dr. Bonnie George, he's a consultant gastroenterologist working at Cherikattu Multi Super Specialty Hospital, Todupuzha. And he has done his MBBS from Pariyara Medical College and MD from BJ Government Medical College, Pune. And he has done his DM from Trivandrum Medical College and has done advanced endoscopy training from Ansh Hospital, Ahmedabad. And especially advanced endoscopy, third space endoscopy, and pancreatico-biliary endoscopy. So he is an advanced endoscopy specialist, I guess. A warm welcome to you, and looking forward to an interesting session. Over to you, Dr. Bonnie.
Thank you, Madam. Actually, I shared the screen. Can you see me and the screen also?
Yes. We can see the screen. Your video has been paused, I guess. Yeah.
Now it's post.
Your image is not visible. Can the others see? I guess your image, the screen is visible. The slide is visible.
Okay, I'm not visible.
Yes,
now.
it's visible now. Fine now.
Okay, ma'am. The screen slide is visible now.
Yeah, slides.
Okay.
Yes,
Thank you, ma'am. Thank you for the warm welcome. Actually, this is actually a wonderful topic to discuss with all of you people. Actually, now I am working as associate consultant in Dr. Rella Institute and Medical Center, Cronpet, Chennai. This is one of the biggest transplant center. Audio is okay? Clear?
Fine, sir. Fine.
Okay, I'm working in Dr. Rella Institute and Medical Center. This is one of the biggest transplant center in India. Actually, one of the means only 2 transplant center. The biggest transplant center is actually belong to this Dr. Rella Institute. I'm working as a advanced endoscopy doctor in Rella Hospital. Recently, since last 1 year, I'm working here. So, coming to the topic, it's NAFLD. Otherwise, actually, most of the time, we know the disease as fatty liver. So, what is actually NAFLD? Actually, NAFLD is just steatosis. What is steatosis? Is actually around 5% accumulation of fat in the liver. So, it is actually histologically categorized into NAFLD and also NASH. NAFLD is having only steatosis. It's nothing to worry. So most of the patients, they will come to us with fatty liver. USG showing some fatty liver, maybe grade 1 fatty liver, grade 2 fatty liver, grade 3 fatty liver. What is this grade 1, grade 2, grade 3? I will describe in the first slide itself. What is grade 1 fatty liver is just like a steatosis, just 5% accumulation of the steatosis or fat accumulation. What is grade 2 is actually in the ultrasound, the fat, because of the hyperechogenicity, you cannot differentiate between the liver and the portal vein. So that is grade 2. Grade 3 means you cannot differentiate between the liver and the diaphragm. That is grade 3 fatty liver. So it's grade 2 and grade 3 is not actually histologically based fibrosis. The fibrosis is the biggest complication, or fibrosis is the complication the patient will, that because of fibrosis, patient will the patient will go into the cirrhosis. That's the biggest complication. And cirrhosis, then the decompensation, then hepatocellular carcinoma. So NAFLD, as I already told you, there is more than 5% hepatocytes histologically having steatosis. What is NASH? NASH is having hepatocyte inflammation. What is inflammation? Hepatocyte will get ballooned. There will be necroinflammation. And histologically, we all know megamitochondria and all these complications. NASH may or may not be associated with fibrosis. If there is a significant fibrosis, that is F2, F3, F4. F4 is actually cirrhosis. Then there is so many things to worry. So what is the prevalence of NAFLD in our country? In our country, just like a European population, it's almost 27 to 30% prevalence is there for NAFLD. So the spectrum of NAFLD, it will start with just a steatosis, that is fatty liver. Then it will become NASH. Then sometimes the fibrosis will come. Then it will, over the time, it will lead to cirrhosis. Then there will be hepatocellular carcinoma, all the complication, bleed, decompensation, ascites, all these are decompensation. What are the liver decompensations? What are the cirrhosis decompensation? There will be ascites, there will be hepatocellular carcinoma, there will be hepatorenal syndrome, there will be hepatopulmonary syndrome, all these complications. We are not dealing with that. Cirrhosis, it's another spectrum, it's a big spectrum. We are not covering anything about cirrhosis. So, as I already told you, steatosis is 5% fat accumulation plus or minus inflammation. That is NAFL, that is non-alcoholic fatty liver. So what will happen with the steatohepatitis? There will be necroinflammation, ballooning, maillary bodies, and megamitochondria will be there. This is a pathological definition. So what will happen to this F1, F2, F3 over the time? Almost, I already told you, if we are seeing 100 patients of fatty liver, 100%, so there will be some 30% with the fatty liver. Over the time, some around 10 to 15 years, there will be 11% of them will go to F2, F3 fibrosis. Then if the patient will develop F2, F3 fibrosis, what will happen to them? Over the next 7 years, either they will go into cirrhosis. If the patient having a cirrhosis, next over this 7% of the patient will go to hepatocellular carcinoma. So there are primary NAFLD, it may be associated with metabolic syndrome, and secondary NAFLD, there will be so many causes, like drugs may be the causes. They may be using steroids, amiodarone, tamoxifen. There may be metabolic association, like dyspeptic lipopyronemia. It can be nutritional, like patient may be in TPN, there may be rapid weight loss. Some patient will be going for bariatric surgery. Bariatric surgery, we will see actually the patient is having fatty liver. Obviously, one surgeon will tell that actually your BMI is some 35, you should go for bariatric surgery. But these patients also will have fatty liver. How? Because of metabolic dysbiome. Actually, we know the microbiota is there. Normal microbiota will have some changes, and the actually the probiotics of the normal microbiota will change into metabolic dysbiome. That's why this patient will be getting NAFLD or NASH in bariatric surgery. Some starvation, small bowel diseases, IBD, all having because of metabolic dysbiome or that this gut microbiota dysbiome. Only because of that they are going to NAFLD. So now we all know that actually it is a metabolic disease, NAFLD. So as per the NCEP criteria, there are definitions to categorize these patients into a metabolic syndrome. How? At least more than 3 out of the 5 criteria should be satisfied. So waist circumference in male it should be more than 102. In female it should be more than 88. Triglyceride level should be more than or equal to 150. HDL cholesterol in male should be less than 40. In female it should be less than 50. BP should be more than or equal to 130/85 millimeters mercury, and fasting plasma glucose should be more than or equal to 110. If they are satisfying more than 3 out of 5, you can categorize the patient is having metabolic syndrome. So if the patient is having metabolic syndrome and if the patient is having fatty liver, if the patient is coming with you with an ultrasound report of fatty liver, you should categorize the patient. If the patient is having a metabolic syndrome, you should look for the NCEP ATP3 criteria. So metabolic syndrome, what are metabolic syndrome? What is metabolic syndrome? There should be components like obesity, hypertension, hyperlipidemia, diabetes, and insulin resistance. So we all know actually the obese patient will be having fatty liver. Is there any chance the lean patient is having metabolic syndrome, or if the lean patient is having predisposition for fatty liver? Yeah, lean patient also having a chance of fatty liver or NASH. These are actually particularly dangerous because of what is happening, because adipocytes, liver. What liver doing in metabolic syndrome is, liver what they will do is, because of multiple fatty acids will come into the liver, and liver with the use of mitochondria, they will beta oxidize it, and it will with the use of lipoproteins, it will the free fatty acids will be modified into VLDL. So if there is a high free fatty acids applied to the liver cannot metabolize all these fatty acids into VLDL. There will be high amount of free fatty acids. Then the free fatty acids will be oxidized. Hello? The free fatty acids will be oxidized, and there will be endoplasmic reticulum stress, and it will lead to necroinflammation. That is actually causing necroinflammation, and this inflammation and hepatocyte ballooning and all these complications. So particularly what happens with the lean, this thing is, so we know actually there are so many, we can
Dr. Boni, you are mute now. Can you please unmute?
am I audible?
Yes, yes.
Yeah. So lean NAFLD particularly, they're having a particularly metabolic dysbiome is more. They are more because we cannot order these patients, you reduce your weight, because already his BMI is almost around 15 or maybe 18 or 20. So how? So these particular patients, we cannot tell them actually you reduce your weight, you reduce the sugar, you reduce all these things. We can tell exercise, but lean NAFLD particularly, they are comorbid. There will be high chance of cardiovascular complications. There will be high chance of hepatocellular carcinoma. So particularly, you have to be more specific with the lean NAFLD patients. So the global prevalence is around 25.24%. Indian population, particularly Middle East, it will be around 31.79%. In India, it is around 27%. So prevalence of NAFLD parallels with the rise in trends of obesity. So when the obese persons are, because so many junk foods are coming, and we are more comorbid, and we are more prone to our sitting type of jobs. So obviously obesity is having a high prevalence in our society. So when the obesity is coming over the time, in India particularly, you are seeing India on the 5th number. It's actually obesity is coming in a high number, and also NAFLD is coming in a rising trends. So when NAFLD is there, or NASH is there, when a fatty liver is coming, there are some comorbid situations. When some actually hepatitis C virus can cause hepatic steatosis, hepatitis B virus can cause steatosis. All these obese patients may be taking alcohol. That is also actually a bias. So maybe they may be taking a significant amount of alcohol. What is a significant amount of alcohol? Significant amount of alcohol in male is they may be taking more than 21 standard drinks per week. Or in a female, they may be taking more than 14 standard drinks per week. What is a standard drink? A standard drink may be containing more than 14 grams of alcohol. So we know actually hot type of alcohol, they may be containing some 30 to 40% of alcohol. So 3 drinks may be containing a significant amount of alcohol. So you have to rule out before categorizing a patient to NAFLD, you have to rule out they may be taking some drugs, they may be taking some steroids, they may be comorbid with the hepatitis C virus, hepatitis B virus, alcohol. So you have to rule out all these type of diseases before labeling a disease, labeling a patient as NAFLD. So Indian scenario, I already told that some 32% are prevalent. So all the time from 1998 to 1994 to 2005 to 2010, NAFLD actually from 3.3 to 10.1% in particularly children and adolescents. So particularly in our children's, they're actually in our childhood, we may be actually used to play in our playgrounds. We may be used to do all type of activity. Now we are all interested in actually education of our childs. Actually, children and adolescents are more prone to NAFLD and NASH type of complication. Sometimes in children's, by around 14-15 years, we have seen patients with cirrhosis. So in 2005 to 2020, it is a 2016 data by Selvakumar. It's actually published in AASLD. So some 10.1% of the population is having NAFLD. Out of this, 3.4% is having actual NASH with the pathologically proven NASH. So why these things are happening? What is the pathological basis? This is actually, we know females with the PCOD, particularly obese patients, they having insulin resistance, metabolic syndrome. That is actually the cause of this NASH or NAFLD steatosis. Why this is happening? Insulin is the most common hormone which is having a metabolic balance in our body. What insulin is doing? Insulin will control the lipogenesis. Insulin will control the lipogenesis. When gluconeogenesis, glycogenolysis, there will be a control. So when the lipogenesis is in control, there will be less free fatty acids. So less free fatty acid means there will be less beta oxidation. There will be less lipid peroxidation. There will be less free radical regeneration. There will be less inflammatory cytokine generation. What in metabolic syndrome happening is there will be insulin resistance. So in liver, the free fatty acids will not be converted into VLDL because there will be insulin is not at all functioning. When insulin is not functioning, the free fatty acids will be beta oxidized into multiple types of free radicals, and NF kappa B, all these things will be elevated. Then hepatic stellate cells. What is hepatic stellate cells? It's actually a dormant cell in the liver. So when some injury is happening into the liver, what will happen is some hedgehog pathway will. What is hedgehog pathway is when whatever injury is happening, we know liver can regenerate. So during the regeneration, the hedgehog pathway will activate. So it is just like when we are having a wound, it will form a scab. Just like hedgehog pathway, it will activate TGF-beta and hepatic stellocytes into myofibroblast. And then the fibrosis will happen, and more than 5% or 10% of the liver will be having fibrosed. And because of the necroinflammation, more of the liver will be fibrosed. And over the time, it will be converting into cirrhosis or F2, F3, F4. That I will be detailing in the next slides. Why this? How we will diagnose F2, F3, F4. If your patient with the fatty liver, is he having a F1 only, symbol F1 only? If he is having a fibrosis grade 2, fibrosis grade 3, fibrosis grade 4 means it is actual cirrhosis. So there are two hits which is happening actually because of insulin resistance and dysregulation of fatty acid metabolism. That is the first hit which will be happening to your patient. What is the second hit? Because of oxidative stress, because of gut endotoxins, because of necroinflammation, maybe because of some hepatitis B virus, maybe because of some inflammation, the second hit will be happening. So every patient who will be coming to your OPD, maybe the first hit is already happened. We have to prevent the oxidative stress. We have to prevent the necroinflammation to happen to your patients. We have to prevent it. That's the thing actually as a physician we have to do. So this slide is already I have already discussed to you, because we have to control the endoplasmic reticulum stress. We have to control the inflammatory response which is happening into the liver. We have to control the endothelial dysfunction which will be happening in the liver. Normal adipocytes, if we are reverting the liver to F1 stage, then the adipocytes will function, the normal liver will be functioning, the free fatty acids will be converting all the things to VLDL, and the adipocytes insulin sensitivity will be happening, the adipocytes will be properly functioning. What adipocytes will be doing, all the chylomicrons which will be absorbed from the intestine will be converting into triglycerides. Then the liver, there won't be any significant damage will be happening. That we have to achieve over the time with your patients by the treatments. We are actually focusing on more over the primary care. We have to convert the patients, we have to revert the patients from F2, F3 into F1. F4 we cannot do because a gastroenterologist or hepatologist have to do the further things because F4 is cirrhosis. All the hepatologist or gastroenterologist, they will manage the patients and they will prevent the patient from decompensation, prevent the patients, they will surveil the patient from, they will do surveillance to prevent the patients from the decompensation or hepatocellular carcinoma which will occur in the due period. So there are some genes, PNPL3, particularly in alcohol or NAFLD. I told you lean NAFLD. Why this lean NAFLD is happening is, one thing is metabolic dysfunction. Obviously, there will be some central adiposity in lean NAFLD patients. Obviously, invisibly there may be lean, but there will be central adiposite deposition. But particularly these patients will be predisposed to PNPL3. All these type of genes, they may be predisposing all these lean NAFLD into NASH and further cirrhosis. That you have to identify, then you have to treat as per, because lean NAFLD treatment itself is a difficult thing for even for a hepatologist or gastroenterologist. We have to identify it. We have to prevent from by giving approved treatment by preventing from F3 to F4. So why this is the estimated progression rate for NAFLD. If we are seeing 100 patients, there will be having 40% of the patient may be having NASH. After this 40% of patient, there may be over the time, there will be 10% will be going into fibrosis. If that out of the 10% of the patients over the time, over the next 7 years to 8 years, there may be going to cirrhosis. And in the cirrhosis patients, over the year, there will be chance of 0.3 to 2.6% per year chance of hepatocellular carcinoma. So what is actually the presentation of NAFLD? If they are coming with some symptoms, no. Most of the times this patient will be coming asymptomatic. Sometimes fatigue is the most predominant symptom. Maybe this NAFLD may be a part of presentation of autoimmune hepatitis. Autoimmune hepatitis like autoimmune hepatitis or this one PBC, PSC, whatever. Most of the this type of patients will be presented with just a fatigue. Maybe sometimes there may be pruritus. So what you will find is some bright liver, that is fatty liver, maybe incidental hepatomegaly. That is the common scenario for these all type of patients. So while during evaluation, obviously you will find out maybe this patient is having type 2 diabetes mellitus. There will maybe this patient may be having dyslipidemia. They may be having hypertension. All these type of metabolic syndrome presentation that you have to identify. So you have to identify. So the patient presented to you with an NAFLD or a fatty liver, you have to identify if the patient is having any type of syndrome of metabolic syndrome. So if the patient is having NASH, that you have to do an LFT. LFT is showing some ALT, AST abnormality. Most of the times, liver enzymes may be normal in 80% of the NAFLD patients. So ALT, AST is not at all sensitive for NAFLD or NASH. Some 80% of the patients, so liver enzymes also be normal. So you cannot send the patients away. So you have to correlate. You have to tell that. So you are having a fatty liver. We don't know. Maybe LFT is maybe normal to you, but we don't know you are having any fibrosis. You may be having a necroinflammation. You may be having some pathological necroinflammation which will be happening inside you. So over the time, over the next 7 years or maybe next 10 years, there will be high chance of NASH, or maybe this NASH may be converting into cirrhosis. That you have to identify, because particularly all these type of patients or even NASH patients, they may be presenting you with a normal liver enzymes. So I told you, you have to exclude some other comorbid conditions, particularly this liver patient is having, like alcohol, hepatitis C virus, they may be taking some steroids, or maybe they may be taking some Ayurvedic medications, they may be taking some Unani medications, they may be predisposed to all type of medications, they may be having some proposed prolonged fasting, maybe that may be the cause of these things that you have to identify from the history. They may be predisposed to some hereditary disorders like Wilson disease, particularly in a young patient, maybe around 14 to 18 years, maybe a teenage patient. They may be having an enzyme abnormality. They may be having a fatty liver without any enzyme abnormality. So you have to rule out Wilson disease, hypobeta-lipidemia, lysosomal or acid lipase deficiency. All these you have to identify. So how to identify, how to evaluate all these patients? So I told you metabolic syndrome you have to identify. So they may be having obesity, type 2 diabetes mellitus, hypertriglyceridemia, metabolic syndrome. So sometimes without any metabolic syndrome, they may be having hypopituitarism, hypothyroidism, obstructive sleep apnea because of obesity, PCOS. So all these things may be some gene. You cannot just tell that actually you do a genetic test. You are a lean patient, you are having a fatty liver. So you have to go for a PNPLA3, TM6SF2 gene mutation to identify. You have to tell, you have to tell that actually you have to undergo some test. Maybe you are having a NASH. If you are having a F1 fibrosis, okay, you can follow, you can do some diet restrictions, you can do some carbohydrate restriction or fat restriction, you can do some exercise that we will be coming into the details in the next slides. But all these things may be associated. That may be the cause of this fatty liver. The confounding factors you have to identify as a primary physician. So our goal one is identify the patients in NAFLD. They are prone for NASH or they are prone for fibrosis. Goal 2 is if there are any significant fibrosis, or if they are having an F2 fibrosis. See, there is a spectrum actually which is showing in the slides. So it's actually a surveillance analysis of 640 years NAFLD patients with the matched controls. F0 F1 patients, it is a 40-year follow-up. F0 F1 patients are actually without any symptoms, without any fibrosis, without any cirrhosis. They're having a proper follow-up. Nothing, there is no symptom, there is no complication, there is no decompensation. But you see, F2 and F3 they are actually means within 20 to 30 years or within 20 years, they are going into fibrosis or they are going for cirrhosis. These patients you have to identify. So that is our primary goal. First thing you have to identify is, are they progressing for fibrosis? Second thing, if they are having a F2 fibrosis, you have to revert the fibrosis. There are some anti-fibrotic treatment. There are some properly ASLD, EASL, or some our ISG guidance is there for proper. There are identified drugs for treatment. So we have to treat the patients. We have to give them some guidelines. You have to do all these treatments to revert the fibrosis into F1 level, or maybe without any fatty liver. We can identify the patients. That is our primary goal. So what is the screening type of patients? ASLD guidance telling that if the patient is having type 2 diabetes mellitus, there is a high index of suspicion for NAFLD or NASH. So you have to risk stratify the patient with the fibrosis scores or transient elastography. So other risk factors also you have to identify. I told you obesity, hypertriglyceridemia, or hypothyroidism. All these things you have to identify. And what are the complications for NAFLD patients? Is this just cirrhosis and complication or decompensation? No. So what is the most common death of a fatty liver disease or most common death of a NASH-related cirrhosis is cardiovascular risk factors. Most of them may be dying with a stroke, or most of them, they may be dying with a cardiovascular arrest, or most of them may be having a myocardial infarction. These patients means these persons we have to identify. They are having any comorbid risk factors like dyslipidemia, metabolic syndrome, all these things we have to identify. That is also our primary concerns. So our primary strategy is identifying NASH and identifying F2 fibrosis. How? So first, obviously, as a primary care physician, obviously we will do liver enzymes. I told you 80% of the patients may be having a normal liver enzymes. So ALT and AST is not sensitivity for to identify patient for to categorize as NASH. You cannot tell that actually your liver enzymes is normal. So you are having only grade 1 fatty liver. You don't do any further investigation. You are good. You cannot do that. Maybe the patient is having F2, F3 fibrosis. Sometimes after 5 years, they may be coming to you with the cirrhosis. So you cannot escape. So that time you are having only grade 1 fatty liver. It is not our duty to give some treatment to F1 fatty liver. That is not a treatment guideline. So you have to identify, is this patient with a grade 1 fatty liver? That grade 1 fatty liver in ultrasound, they are just mentioned as grade 1 fatty liver. You cannot tell the patient, okay, it is grade 1 fatty liver enzymes is normal. You cannot send the patient away. We have to evaluate and investigate. How? So there are some criteria to categorize the patients into NASH. So you cannot do a liver biopsy in all these patients. You cannot tell the patients that sure, your patient, you may be predisposed to NASH, and in the meantime, you may be going for cirrhosis. So you have to go for a liver cirrhosis, or you have to do an endoscopy to rule out any varices to rule out portal hypertension. You cannot directly send them away for a CT scan. So there are some methods to identify non-invasively from for F2 and F3 fibrosis that we will be discussing in the further slides. In ultrasound, obviously there are some 61 to 100%. If the fatty liver is more than, I told you, more than 5% steatosis is fatty liver. If the more than 5% steatosis, 61% of the patients you can identify by using just ultrasound. If the fatty liver is, if the status is more than 20%, almost around 100% we can identify with just using an ultrasound. So you cannot tell the patients that actually you just go for a CT. Only some 79% sensitivity is for that. So better strategy is just do an ultrasound. So I told you this liver biopsy we will be discussing in the further slides. There is one strategy, there is one entity which is called serum ferritin, or means some people maybe you have noted that actually some ALT may be normal, but serum ferritin is high, serum iron is high. So one entity called hemochromatosis, particularly in 50 to 60 year old patients, particularly in male patients, they may be having high serum iron, serum ferritin. You cannot label that actually every patient is having hemochromatosis. Particularly in NIFLD, there is something called serum iron accumulation. So serum iron accumulation is there. So in NIFLD patient also, this serum iron and serum ferritin may be high. So you cannot tell that actually serum iron, serum ferritin is high. You cannot tell that actually this patient is having this hemochromatosis. You just go for a this one transferrin saturation. You don't send the patient away. So sometimes this NIFLD or NASH patient also may be having high level of serum iron, serum ferritin, or sometimes autoimmune hepatitis, or sometimes this PSC, PBC, all may be patients with the asymptomatic presentation. They may be presenting you with NASH or NIFLD. So I told you this is the pattern: normal liver, NIFLD, NASH, and cirrhosis. Whom to biopsy? So in F2, F3 with the liver enzymes elevation, and if there any some other comorbid condition like hepatitis B virus, hepatitis C virus, some autoimmune hepatitis, PBC or PSC, you're suspecting actually, you cannot just clearly identify that actually this patient is directly affecting from fatty liver or NASH. Maybe this patient may be having hepatitis B virus or hepatitis virus. That time you can send the patient for a liver biopsy to a hepatologist or a gastroenterologist. Otherwise, you can non-invasively categorize the patient is having F2, F3 fibrosis. You can treat the patient with an antifibrotic or NASH type of treatment. So this is the METAVIR scoring system. I told you this is F0, nothing to worry. F1, there is actually perisinusoidal fibrosis that you can see. F2, there is fibrosis which is extending between the two portal triads. That blue thing is actually a trichrome stain, which is particularly for fibrosis. So F3 and F4, have you seen actually any particular abnormality? See, from the portal triad, the cirrhosis or the fibrosis is extending between the two portal triads. So it is making a nodule. That is actually a nodular transformation of the liver. That is what we are telling us micronodular or macronodular cirrhosis. Particularly in fatty liver, it is macronodular cirrhosis. So this macronodule we are seeing in F4. This is Metavir scoring. Particularly after liver biopsy, we are sending to a pathologist or particularly a GA pathologist. They will identify this F3, F4 fibrosis. F3, F4 fibrosis. F4 means it's not fibrosis, actually cirrhosis. You have to treat the patient as cirrhotic patient only. So there is something called the NAS score. You heard that actually some phase 2 trial, phase 3 trial is going on for NASH. So these people are using this NAS score. So what they're using is ballooning, hepatocyte ballooning in lobular inflammation and steatosis. If the steatosis is there, if the steatosis is some 33 to 66%, ballooning is significant, the lobular inflammation is significant. So if the NAS score is around 5 to 8, it is typically or most probably NASH by the liver biopsy specimen. You have to use liver biopsy only if there is we are suspecting an F3, F4, more than F3 fibrosis, or if there is any confounding factor is there like hepatitis B, hepatitis C, or any other autoimmune hepatitis like these things, then only you have to go for. Or if I told you in phase 2 and phase 3 trial of some medication, they are using this NIS score. If the NIS score is somewhere around 9, and over the next 6 months, over the trials, if they are getting a 2 points less, means actually that is the accepted criteria for accepting that drug as doing some wonder thing. There is actually fibrosis getting reduced. Then only this FDA or our CDC will accept any drugs for treatment of NASH. So identifying NASH and F2 fibrosis, there are some new strategies, some non-invasive strategies. There are some non-invasive things, something called the serum-based scores. You can just do a blood test and you can identify F2, F3 fibrosis by around a significant sensitivity. Something called APRI, that is AST to platelet ratio index, FIB4 index, NAFLD fibrosis score, BARD score. All these components I have mentioned, these things are available in internet. NAFLD fibrosis score is available in internet. BARD is available in internet. FIB4 score is available in internet. If particular score is high, the score I will tell you in the further slides, you will be identifying these patients as F2, F3 fibrosis without any liver biopsy. So this is the NAFLD fibrosis score. The parameters are AJ, AST, ALT, platelet count, BMA, albumin, embedded fasting glucose, and FIB4 score is only using some 4 components: AJ, AST, ALT, platelet count. So if the FIB4 score is having more than 2.67, if the NAFLD fibrosis score is more than 0.68, you can, with a high cutoff, there will be a high probability of F3, F4 fibrosis. So with this just a simple score of, with this just a simple online available score, you can just categorize your patient as F2, F3 fibrosis. Then you can send the patient for a hepatologist or a gastroenterologist for further criteria. If the patient is having an NAFLD fibrosis score less than 0.68, if the FIB4 score is less than 2.67, you can obviously treat the patient by giving some advice like diet regulations or exercise, all these things. So we know now NAFLD fibrosis score and FIB4 score. This is very useful score. All the people, particularly gastroenterologists, hepatologists, people are using this score and they are having a significant sensitivity for ruling out F3 and F4 fibrosis. So there are some ultrasound criteria also. Ultrasound methods are also there. So particularly, you can send the patient for a radiologist. You may be heard about fibroscan. You may be heard about 2D shear wave elastography. What they are doing is, in a fibrotic liver, the shear wave or some acoustic impulses, they may be traveling in a very high speed. So they may be categorizing in kilopascals. So in fibroscan, particularly, if the fibroscan, if the shear wave in some kilopascal, they will mention some score. If it is more than 5, if it is less than 5. If it is less than 5 means less fibrosis. if 2D shear wave elastography is mentioning less than 8, there is less fibrosis. And you can also send for some MR elastography, that is a costly method, MR elastography, MR spectroscopy. If it is more than 3.1, obviously you can identify the patient with a high fibrosis score. So with just an ultrasound and with just a basic serum test, we can identify our patient as F2, F3 fibrosis. So either we can do ultrasound with a fibroscan. Fibroscan, obviously, the fibroscan may be available in for free in multiple hospitals nowadays. Actually, per monthly they are coming. They are assessing the liver stiffness. If the liver stiffness is more, the fibrosis is more. It's just simple as that. So what is they are doing is actually they will take some 10 measurements. So they will use a vibrator. They will use a fibroscan probe in 10. They will take 10 measurements. Average they will take, and they will give a particular value based on that fibrosis. Based on the value, the fibroscan value is this thing, and you may be getting this fibroscan. I will tell you the fibroscan values in the later slides. It's a quick bedside test by just doing a fibroscan, or maybe using that FIB4 or NFS score, you can identify your patient as F2, F3 fibrosis. So fibrosis scan value normally is 6. 6 to 8 is there is F1, F2 fibrosis, that is perisinusoidal or portal fibrosis. If the F3 fibrosis, if they are giving a value of 8 to 12, there may be significant fibrosis, F3 fibrosis. You have to send the patient to a specialist. F4 fibrosis, obviously, it is erotic. If the patient means you have to treat the patient as cirrhotic. So 2D shear wave elastography, just like it is actually better test than fibroscan. What they are doing is actually they will not do a 10 measurements. They will do a 3 to 5 measurements in different type of liver, in different areas of liver. They are doing 2D shear wave elastography. So that's why fibroscan is actually only doing in a single area. So 2D shear wave elastography, they will be assessing in different areas of liver. So 2D shear wave elastography, if you are available in your hospital, if it is available, 2D shear wave elastography is having a better sensitivity and better specificity than fibroscan. So 2D shear wave elastography, if it is more than 8.7, F2, F3 fibrosis, or F3 fibrosis, you have to send your specialist. If less than F3 fibrosis, you treat the patient. MR elastography is also there, but I don't think actually it is significant. F3 MR elastography, if you are not getting any significant value in 2D shear wave elastography or fibroscan, then only this MR elastography will come into the picture. So fibroscan and 2D shear wave elastography is okay. So otherwise, without any ultrasound, you can do this AST-ALT ratio. If it is more than 1, there is F3, F4 fibrosis. Upper value, if it is more than 2, it is just cirrhosis. And particularly, you have to see the platelet count. Maybe some they don't. Chronically, the patient is having a less than 1.5 lakh platelet. Obviously, the maybe patient is having a portal hypertension. You have to do an ultrasound. Ultrasound, you can do a fibroscan or 2D shear wave elastography. If the 2D shear wave elastography is more than 10, 11, 12, whatever, if it is less than 7, okay, nothing. You have to do a hepatitis B virus, hepatitis C virus, all this screening. If there is nothing, if the platelet count is more than 1.5 lakh, nothing to worry. If the platelet count is less than 1.5 lakh, you have to do an ultrasound, you have to see the splenomegaly, all these things. And if the portal vein, if it is more than 11 millimeter particularly, it is suggesting of portal hypertension. So there is something to worry. You have to go for that non-invasive this thing, and these elastography things will come into the picture. So I told you in hepatitis B virus, hepatitis C virus, NAFLD, all these things, there are different types of values. Particularly NAFLD, I told you that 6 to 8, 8 to 12, and more than 12, that is the value. So you can use this. So bridging is all together. Non-invasively, you can stratify the patient with more than F2 fibrosis. You can reliably exclude advanced fibrosis. You can non-invasively by using some ultrasound, like I told you, fibroscan. The VCTV is vibration controlled transient elastography. Simply, it is called a fibroscan. 2D shear wave elastography, MR elastography. You can do whatever sources you are available. You can do all these things. Non-invasively, you can categorize how much level of fibrosis your patient is having. So these are the future diagnostic methods. We are not discussing all these serum hyaluronidase. These are all coming nowadays. MicroRNA, alpha-2 microglobulins, all these things. That is nowadays. It's not means they are evaluating all high-profile things. So this is actually I told you means so many things I discussed with you. This is actually in a nutshell how to confirm NAFLD. Second and third things. And obviously, you have to rule out alcohol consumption, significant amount of alcohol consumption. Whether your patient is taking alcohol, you have to rule out. Whether the patient is having jaundice, you have to do that. Hepatitis B virus, C virus, whatever, diabetes mellitus, hypothyroidism, PCOS, all metabolic components you have to rule out. If the BMI is more than 29.9, if the age is more than 40, you have to rule out metabolic syndrome. Non-invasively, you can categorize. You can use FIB4, you can use APRI, you can use AST-LD score, you can use FibroScan, and you can rule out all other causes of liver enzyme elevation I told you. So high risk profile, these times you have to consider liver biopsy, or you have to rule a confirmatory testing like MR elastography, particularly FIB4 level more than 2.67, NFS score more than 6.68, FibroScan showing a value of more than 11, APRI score is APRI score. All these things before NFS, APRI score, it is available online. You can do that. If your patient's platelet count is less than 1.5 level, if the ALT level is more than AST, you can consider liver biopsy or a confirmatory testing like MR elastography. So now we categorized our patient with some non-invasive test, like I told you. If your patient is having fatty liver with just liver LFT, you cannot categorize the patient is not having NASH. You have to do a FibroScan. You have to do some AST, the NFS FIB4 score, or even FibroScan or 2D shear elastography. If it is getting a value of F3 fibrosis, you have to treat the patient. If the F1 fibrosis is there, there are some criteria for management of NAFLD NASH that we are going to discuss in the further slides. So I told you metabolic syndrome is a big component or a significant component of NAFLD or NASH. So weight loss. So particularly because of junk food, because of less mobile activity, all these patients are predisposed to cardiovascular risk factors. They may be having a high chance of NASH. They may be going for F2, F3 fibrosis. You have to tell your patients there are some modalities for treatment. There may be some weight loss regimen. There may be some lifestyle modifications. There may be some weight loss modifications. There may be indicated from bariatric surgery. There may be indicated for bariatric endoscopies. There are nowadays all these patients may be not willing for bariatric surgery because they may be going for a big modification in their own system that from the big surgery. Obviously, affordability may be the concern. So nutritional component, because particularly bariatric surgery, they may be having a nutritional deficiency. Or in the future, they may be having significant nutritional deficiency. You cannot send all your patients for bariatric surgery if they are having comorbid obesity. There are some endoscopic modalities also for just like endoscopic ballooning that I will be discussing and showed in the future slides. You have to treat your patients with diabetes mellitus. Particularly, you have to treat cardiovascular risk factors like hypertension, dyslipidemia, all these things. And you have to treat the patients, particularly that is our concern with the liver-directed treatment also. Some things are there I will be discussing in the future slides. So how much weight loss you have to advise to your patients? So your BMI, your patient's BMI is around 30. Should you send the patient for bariatric surgery? Or should you just advise for some weight loss? Or you just advise for just do some exercise, you will be better. So it's actually in EASLD or ASLD guidelines, these are the boards. They are accepting, they are doing all these trials for actually for F2, F3 fibrosis. It has been found out that 3 to 5% of weight loss will improve steatosis. If you are telling your patients some 7 to 10% of weight loss, it will achieve the NASH will be modified. That histopathology also will get modified. So if your patient is having F2F3 fibrosis, there are some role for weight loss. There are some role for exercise. So if your patient is getting 7 to 10% of weight loss, they may be getting a histopathological resolution. So if your BMI is around 25 to 30%, you are not having any other significant comorbidities, you can go for weight loss strategies for around 7 to 10% weight loss. But all these things actually, they may not be compliant. You cannot, even you also, means it is very difficult to get a significant weight loss. Around 10% weight loss for a 90%, 90 kg patient is around 9 kg weight loss he has to achieve in 6 months. Actually, it may not be practical. That time these drugs will be coming into the picture. Or even you can send the patient for bariatric surgery or bariatric endoscopy. So ASLE guidelines, they are telling that actually reducing calorie is very important. If you are achieving 7 to 10% of weight loss, it will improve histopathological improvement, particularly F2F3 fibrosis. You can revert from F2F3 fibrosis to F1 fibrosis, or maybe a normal liver, they may be achieving. So what diet you will prescribe to your patients? Just sugar restriction, just fat, you just avoid your high fat diets. There are some guidelines. So it is actually a historical, it's actually a pyramid which is showing that actually if your patient is getting a 10% of weight loss over the time, there is actually over the 1 year or 6 months, the patient may be getting a sustained weight loss of around 10%. It has been proven that there will be histopathological resolution, and the fibrosis regression is there. If they are getting only 3% and 5%, only steatosis will improve. They should get around 7 to 10% of weight loss. So the BMI is more than 27. There are other things. If the BMI is more than 35, that is comorbid obesity, that is morbid obesity, then surgical approaches, or you can go for a pharmacological approaches along with the weight loss, or carb, or even diet restrictions. So degree of weight loss, it is being found out that actually even endoscopic practice guidelines, it is showing that degree of weight loss, it is correlating with the NASH improvement. That is 10%, 7 to 10% weight loss is correlating with the NASH improvement. So it will be, if your patient is actually sustainable over long time, obviously your patient will be improving from F2F3 fibrosis to F1 fibrosis, or maybe long time from fatty liver also. So what is the optimal diet in NAFLD? So just sugar restrictions. This is actually a chart which is showing that actually this added sugar or sugar sweetened beverages or total fructose. If the patient is having some fructose related or fructose corn syrup, over the time, that it's around 10 to even over 10 years, 1988 to 2011-22 study, it is showing that actually it is conducted over some 20-30 years. It is showing that actually if the patient is taking added sugar with obesity and NAFLD as a component, they are going for a NASH. So this added sugar obviously will lead your patients to steatosis, NASH, and further into cirrhosis. Particularly, I specifically mentioned fructose. What is happening with the fructose? I told you glucose, obviously, with the use of insulin, it will be during the lipogenesis pathway, it will be used for the lipogenesis or ketogenesis. With the use of insulin, it will be converted into VLDL. But fructose, there is a separate component or separate pathway. Fructose, particularly directly absorbed by the portal vein, directly absorbed into the liver, it will directly stimulate lipogenesis. It is not just like a normal sugar. The particularly fructose component, it will directly stimulate lipogenesis, and lipogenesis or ketogenesis, it will directly stimulate lipogenesis means further necroinflammation and fibrosis. So fructose component or corn syrup, whatever added sugar, it will specifically cause your patients into from NAFLD to NASH and further cirrhosis. So this complex sugars, I just in the slides we can see starch or complex carbohydrates. It is a polymer of glucose. If the insulin sensitivity is good, obviously you can do insulin. You can do all these things like what we are doing for bettering our insulin sensitivity. We can reduce our weight. We can reduce the carb component. We can reduce fat component. Then insulin sensitivity will improve, and further necrotic inflammation will reduce. But if fructose component is there, if the complicated carbohydrate is there, obviously it will stimulate de novo lipogenesis and it will stimulate the liver for necrotic inflammation. So it is not just carbohydrate restriction. Or if the insulin sensitivity is good, so the carbohydrate, okay, means the carbohydrate, if the patient is using high carbohydrate diet, you can do this weight restrictions and high carbohydrate restriction. But specifically, you have to tell that artificial sweetness, high corn syrup, high fructose syrup, or added sugars, or added sweetness. So we are telling that actually you don't use sugar, you just use artificial sweetness. Artificial sweetness will not do any work. Artificial sweetness also, there is specifically, it will stimulate lipogenesis. You have to reduce artificial sweetness also. So sugar rises insulin level. Obviously, we all know that. If the insulin resistance is there, it will stimulate metabolic dysfunction, gut dysbiome, and it will cause NASH histology to fibrosis and to cirrhosis. So should a dietary sugar restriction is just enough? Limiting hepatic exposure to fructose particularly will prove beneficial in your patients. Fructose and also added sugars. So should they use non-nutritive sweetness? Non-nutritive sweetness, they may be beneficial, they may be neutral. Diet soda you can advise because it is not associated with a significant ALT elevation. But sugar sweetened beverages significantly associated elevated ALT. I told you, sugar sweetened beverages like soda, Coke, Pepsi, obviously they will be causing dose dependent, and particularly they will increase the BMI. They will, in long time, they will be causing necrotic inflammation and further this one. And also Framingham Heart Study it shown that cardiovascular risk factors will also cause all these things. So what diet restriction you have to advise to your patients? Nowadays, all these patients will be asking for this one, intermittent fasting, or some Ramadan type of fasting, or this actually alternative fasting. Actually, it has been found out that. So all these type of things, intermittent fasting specifically, 5 days diet and 2 days of fasting. Second thing, actually, like the Ramadan fasting, like the morning take a diet, and in the evening you take a diet, particularly some 30% reduction of diet or 30% reduction of calorie. That if you are taking some 3 chapatis in the night, if you can reduce the 3 chapatis to 1 chapati or 1.5 chapati, it will increase the insulin sensitivity. For long-term studies, it has been proven that actually this intermittent fasting or Ramadan type of fasting, or the one alternative type of fasting, or this morning and night diet with the avoidance of means lunch, it has been proven that there are some insulin, the chance of insulin sensitivity improve, and in the long time, the fibros also improve, even cardiovascular factors also will get improved. So particularly, what happens with the insulin sensitivity is in the morning specifically, and obviously as a diabetologist, you know that actually insulin sensitivity most important time for improved insulin sensitivity in our body is morning. Around compared to all the time, our body is having more insulin sensitivity in the morning. Some 30% improved insulin sensitivity is happening in our body in the morning. If you are taking a good breakfast, if you are reducing some 30% of calorie in the night, and if you can, you just reduce your calorie in the lunch also, that is more than enough for a grade 1 or grade 2 fatty liver to get improved from F2 to F1 or F1 to normal liver. So all these studies are actually having a good data also. So low calorie diet is better, one thing. So should you just reduce low carb diet only? Should you reduce fat? So low carbohydrate is associated with a significant reduction in intrahepatic lipid component because it will reduce lipogenesis that we in the I already discussed multiple times. Actually, maybe you may be bored with this lipogenesis. So carbohydrate reduction obviously will reduce lipogenesis. One thing. Second thing. So heart healthy. Obviously, I told you have to reduce the dyslipidemia. You have to reduce the atherogenesis. You have to reduce smoking. You have to reduce alcohol. That also is a part and parcel. You have to advise to your patient that you have it because NAFLD, most of the comorbidities are coming from cardiovascular risk factors, not just like HCC, not like a decompensated cirrhosis, not causing mortality to the patient. It is the cardiovascular risk factors they are causing mortality to the patients. So should you restrict low fat also? So you have to reduce fat also. In actually, this is a comparison study using low carb and low fat. So it has been proven that it's significant p-value. It has been proven that actually low carb, low fat diet in a grade 1, grade 2 fatty liver over the long time, it is superior for lowering LDL and total cholesterol. Particularly, it will reduce the dyslipidemia. Particularly, it will reduce the cardiovascular risk factors. Low carb particularly will help the insulin sensitivity. Low fat diet particularly will improve the cardiovascular risk factors in your patients. So it will reduce the cardiovascular risk factors. It will reduce the cardiovascular risk, morbidity. Second thing, low carb diet will improve your insulin sensitivity. It will reduce the fibrosis. So you have to tell your patients you have to go for low fat or low carb diet. So you maybe heard about so much diets like Atkins diets, keto diet, Mediterranean diet, all these things. Which diet may be good? So you maybe heard about this Mediterranean diet. Mediterranean diet particularly, they have proper provision for protein. They are having proper provision for carbohydrate. They have proper provision for protein also. So carbohydrate, protein, and fat. There are proper provisions, particularly some 30% actually provisions in Mediterranean diet. So even Mediterranean diet and low fat, low carb diet. Mediterranean diet, particularly, it is a low fat, high carb diet, but particularly it is having high monounsaturated fatty acid. It is not polyunsaturated fatty acid. Monounsaturated fatty acid, I told you, lipogenesis will not increase with the monounsaturated fatty acids. So monounsaturated fatty acids, monounsaturated fatty acids are higher in Mediterranean diet. So we are having if your patient is asking for Mediterranean diet, can I follow Mediterranean diet? With Mediterranean diet is good with the calorie restrictions, with the proper exercise. Mediterranean diet you can advise to your patients. So, restricted diet with proper adherence is important because you may be your patients or maybe us may be going for some diet restriction over some 2-3 months. Then we will tell that actually, I have achieved some 3-5 kgs weight loss. Now my fatty liver is also, my doctor is telling that actually my LFT is normal. My fatty liver is also improved. Okay, can you go for the normal diet pattern? No. The adherence is the important thing. Actually, you have to adhere with the diet restriction or your adherence with the exercise and diet restrictions. Because NAFLD, you know that actually even after transplant, these patients are actually prone for recurrence. Particularly, they are going for cardiovascular complications like myocardial infarction. They may be going for a stroke because just after actually transplant, you may not be saved from actually NAFLD complication because it is actually in your body, lipogenesis is happening. It is a metabolic dysfunction. It's not just like the liver complication. It is actually in their body, the things are happening. So you have to adhere with the particular diet. You have to reduce the lipogenesis. You have to improve your insulin sensitivity. That is the prime key. you have to improve your insulin sensitivity, particularly if you are having F2F3 fibrosis. Your adherence and restriction of calories and adherence with the exercise pattern. That is the most important thing. So rationale, timing of energy intake. I told you intermittent fasting is good. Alternate day fasting is good if they are well and good, if they are adhering with the particular pattern. If you are okay with this alternate day diet, if you are doing with the intermittent fasting, that is well and good. Timed restriction of diet, that is also good. Particularly what it has been found out that restriction of calorie, particularly if you can reduce 30% of the calorie, if you can reduce 30%, can reduce 10%, 5 to 10% of weight. So I told you 5 to 10% of weight loss. Second thing is 30% of calorie restriction. That is around, if you can reduce 700 to 1000 calories in your diet, 700 to 1000 calories in your diet, that is the most important thing. Around 700 to 1000 calories you have to deficit in your food pattern. Second thing is around 10% of weight loss. Third thing is exercise. What exercise actually it is being advised? Exercise, particularly 200 minutes of exercise per week. 200 minutes of exercise. Which exercise is actually good? Exercise actually endurance exercise like this one. There are two types of exercise we know: cardio. Then second thing is actually resistant type of exercise, weight training. Both are good actually. Resistant training is better. I told you lean NFLD patients what we can ascribe, because the lean NFLD patient will tell you I am more comorbid to the cirrhosis. You doctor, you are telling that actually as a lean NFLD patient, you are more comorbid to cardiovascular factors and cirrhosis also. But what advice you can give to me? The thing you can give to them is exercise. Just do exercise. Second thing is restriction of calories. You cannot tell that actually restriction of diet because already they have BMI around 18 or 20. But you can do exercise. You can improve your insulin sensitivity. You can reduce your metabolic dysfunction. So all these things are important. So exercise is a very important thing. 200 minutes of exercise. Whatever things, cardio exercise is okay. Particularly exercise, what to achieve is around 70% of maximal heart rate you have to achieve by doing a cardio or whatever resistance training. 70%. What is maximal heart rate? This is just a simple thing. 200 minus age. 200 minus age means I am 35. 200 minus 35 is around 165. So 165 of that 165, 70% you have to achieve. So around 140 beats per minute. You have to achieve by your 140 to 150 beats per minute. You have to achieve by your exercise. Just maintain that exercise. That is the proper exercise you have to do. That is resistance or endurance training or whatever cardio exercise, whatever you are going to do. So either you have to do 5 days exercise, proper 5 days exercise, 5 days per week, or if you are doing a 30 minutes exercise, you have to do daily for 7 weeks. If you are doing a 40 minutes exercise, you can skip 2 days. Around 5 days you have to exercise of the 7 days. Means over the 7 days you have to do 5 days exercise. 40 minutes exercise 5 days, 30 minutes exercise daily for week. You have to achieve 70% of your maximal heart rate. This is the guidelines for exercise. Any vitamin supplements you have to give? You know, vitamin E, vitamin D supplements, they are good. Vitamin E supplements, you know, so much people are heard about P1s. There is one trial called P1s trial. Some 247 patients, they have been tried. It has been found out that there is a resolution of NASH. Even fibrosis also improved. So the one question from you people are, so can I prescribe any vitamin E to a biopsy-proven patient with the cirrhosis? There are some studies with the basic common sense cirrhosis with active LFT elevation. Without any diabetes, you can prescribe vitamin E to these type of patients. Particularly 800 vitamin E, 800 international unit per day, you have to give to your patients. So this vitamin E is prescribable, particularly to F2, F3 patients. Not at all. So many studies are not there in cirrhosis. but your patient is okay, there is no decompensation, there is only cirrhosis compensated status. Even in some studies, it has been found out that actually some resolution of steatosis, so resolution of necroinflammation in F4 patient also. So NAFLD in ASLD guidelines saying that 800 international unit per day improve your patient's liver histology. Vitamin D, what they will do is actually it will improve the it will because hepatocyte stellate cells, they are actually in dormant state. So during inflammation, this hepatocyte stellate cells will convert into myofibroblast status. They will cause fibrosis. They will cause perisinusoidal fibroblast activation, and they will cause fibrosis. What they have been found out that vitamin D receptor will activate, they will keep the hepatocyte stellate in dormant stage. So the chance of anti-fibrogenesis, there are less chance of fibrogenesis in these type of patients. You can give vitamin D also. Vitamin D can decrease ALT patients, ALT in your patients. It will not improve significant. Already fibrosis there, then there is no chance of improvement. But if there is only F1 fibrosis, you can give some vitamin D also. So vitamin D and vitamin E are prescribable. Good healthy habits, I already told you, the Mediterranean type of thing, you have to increase water intake, because water intake reduce the toxin level in your body. You have to take a proper healthy lifestyle. You have to reduce artificial sweetness. You have to reduce fructose, corn syrup, high artificial sweetness, or this soda beverages. And you have to reduce your 1000 calories per day. Exercise, I told you, it will reduce the NAFLD component to at least 20%. So if you are doing an exercise of at least 200 minutes per week, it will reduce central adiposity, it will increase the insulin sensitivity, it will reduce the metabolic syndrome, and severity of NASH will also be improved. Even in cirrhosis patient, it is being advised. What is the moderate? So vigorous sensitivity means jogging, running, rope jumping, all these things. Moderate type of exercise means that we are actually know that actually your patient may be doing it bicycling or walking in around 5.5 km per hour in treadmill, whatever. All these things, these are advisable. So moderate type of moderate intensity, that is around 40 minutes per day for 5 days per week is advisable. Vigorous intensity is okay if your patient is not having any cardiovascular risk factors. Vigorous sensitivity is also advisable. Maybe because all these patients may be having cardiovascular things also, because they are obese. They may be having myocardial infarction predisposition. You have to do a 2D echo. 2D echo is not showing any significant RWMA. Your patient is okay, well and enough. They are fit to go for vigorous type of sensitivity, vigorous type of exercise. Then only it is advisable. Otherwise, moderate type of exercise is advisable. 40 minutes per day is advisable. So exercise already told you. This is the slides for you. Hypocaloric diet, 500 to 1000 kilocalorie deficiency. Moderate type of intensity exercise, not vigorous types. Vigorous type is also advisable if you are good, your heart is good, there is no significant dyslipidemia, there is no significant atherogenic, and if your patient is getting sustainable weight loss, around 7 to 10% of weight loss, well and good. F2, F3 fibrosis will improve. If the F3 fibrosis is there, better take care by the hepatologist or gastroenterologist. If F2, okay, well and good, you can treat. There is no significant steatosis. I already told you FibroScan, 2D shape wave, whatever you can use it. So these are the pharmacological treatment of NASH in nutshell. I will tell you in very limited time. I know so many slides are there. I'm boring you. So these are the things actually I told you. Get this one thing. Second thing is modulating metabolic production. Third thing is actually inhibiting the translocation of bacteria, inhibiting the metabolites into the liver. So there are some studies, bovine cholesterol not advisable. Orlistat, you maybe heard that actually some patients, some doctor may be giving, say, this orlistat is actually, they will reduce the absorption of dietary fat. This will give you, there may be having some steatoria, but you may be getting significant weight loss. it will reduce your fatty liver, but it is not at all advisable. There is no data to support the use of orlistat as a treatment for NAFLD, or there is no data to advise this orlistat as a treatment for NASH also. Because orlistat will cause fat malabsorption, it will cause significant steatorrhea, malabsorption, and patient will not be adherent to you, and don't prescribe. There is no data. So treatments targeting metabolic pathways, thiazolidine, obviously pioglitazone. Oh, what is pioglitazone? You know that it is a PPAR gamma agonist. PPAR gamma agonist, it will work the things in adipocytes. What adipocytes will do? Part of lipogenesis. It will not stimulate lipogenesis. It will store the fat as triglycerides in the adipocytes. So PPAR gamma, in one way it is good. PPAR gamma agonist is good, pioglitazone, but the thing is actually in diabetic patients or in cardiovascular disease, pioglitazone will cause volume overload. Sometimes it can cause heart failure. So PPAR gamma agonist is advisable. It can cause hepatic steatosis improvement. It can improve hepatic steatosis, but it will not revert fibrosis. It will improve ALT. It will improve steatosis also, but it will not revert fibrosis. With proper precaution only you have to use pioglitazone. There are some studies with supporting pioglitazone. Pioglitazone, it is advisable. So this is the treatment. Actually, nowadays, everybody is, so hepatologist, gastroenterologist, everybody is giving saroglitazone. What is saroglitazone? Actually, it is a PPAR gamma alpha agonist. What is they are doing is actually it is an alpha gamma agonist. Alpha, what they are doing is it will improve the insulin sensitivity. Gamma, what they are doing is it will reduce the lipogenesis. So it has two things. It will reduce dyslipidemia. It will increase insulin sensitivity. So it is advisable in diabetic patients because it will improve insulin sensitivity. So it can be given in diabetic dyslipidemia. It can be given in diabetic dyslipidemia with the fatty liver or NASH patients. It is the only drug nowadays. It is approved by FDA. It is approved by CDC. It is saroglitazone doses. You all know the brand name is Biluxa 4 milligram. It is advisable, but you have to do fibroscan. You have to do sensitivity shear elastography. If you don't know if the patient is having significant fibrosis, at least you have to take a gastroenterologist, hepatologist opinion prior to. Then they will coming back to you, obviously. Particularly, you are the primary consultant. So obviously, for the super specialists, they are not the primary consultant. Obviously, they will come back to you. Then you can follow the patients. So how many days you have to give? That is also a question. You maybe heard about this obeticholic acid. So some trial is like a Flint trial. It has been found out that it is in grade 3 trial nowadays. Means phase 3 trial. It is not being approved. So in phase 3 trial, over 72 weeks by obeticholic acid around 25 milligram and 10 milligram. There are two doses, 25 milligram and 10 milligram. It has been found out that NIS score, that is steatosis score, that is that pathological score, it is improved by more than 2 in 72 in F2, F3 patients. But it is in phase 3 trial only. It is not being found out that there are significant some complication. It has been found out that what they are doing is obeticholic acid is a FGR agonist. So what they are doing is actually it will stimulate the FGR. It is a nuclear receptor agonist. It will stimulate the FGR. It will reduce lipogenesis. It will increase insulin sensitivity. But the thing is actually VLDL or LDL, so HDL it will reduce and LDL it will increase. So hyperdyslipidemia, it's a complication of obeticholic acid. Second thing is pruritus. That we don't know. It's an complication is actually pruritus and hyperdyslipidemia. It is not being approved. So some people, some pharma people may be coming to you that obeticholic acid is approved. You can give, but actually it is not being approved. There is no significant fibrosis improvement. There is no significant status improvement. Actually, it is in phase 3 trial. It has been shown that NIS score is improved by 2, but it is still in trials. Liraglutide is actually, it's an ingredient. Liraglutide and semaglutide, actually, it is coming into practice obviously it will come into practice. It will improve the insulin sensitivity. It's a GLP-1 analog. It will increase the insulin sensitivity. So liraglutide in 1.8 milligram per day and semaglutide in 100 milligram per day. This one, semaglutide, it will come into practice in more by around 2024 end. So these are the things. Statin obviously it will improve the cardiovascular risk factors, and there are some studies actually statin will improve fibrosis. So biopsy-proven fibrosis with the dyslipidemia and diabetic patients, we can give some 10 milligram per day. There are some data. So all these things are actually not used. Some antifibrotics are also there. So these are so many drugs are coming. So these are the trials enabled. You see GLP-1 analogs, SGLT1 analogs, DP4 analogs, CCR5 antagonist, whatever. All these things are sensitizing on insulin, improving the insulin resistance, decreasing the lipotoxicity, improving the oxidative stress, decreasing the inflammation, decreasing the necroinflammation, reducing the cell apoptosis and the fibrogenesis. All these things are in trials only. Actually, it is actually NASH is a actually there are no significant drugs. We have there are so many drugs in pipeline. It will obviously by around 2024, 2025 they will come into practice. The thing is actually for a primary consultant, the thing is reduce weight around 7 to 10% of weight loss, carbohydrate restriction, low carb, low fat diet, reduce the artificial sweetness, reduce obesity, do the exercise properly around 200 minutes per day. Adherence is the proper key. Be adherent. Then you can do alternate fasting, alternate day fasting, intermittent fasting. You can follow a Mediterranean diet, whatever. Then comorbid components like hepatitis B, hepatitis C virus that you have to identify. If there is something, you have to do this. If you are suspecting F2F3 fibrosis, you have to non-invasively categorize F2F3 fibrosis by using ALT, SP score, RT score, FIB4 score, NFS score, everything I mentioned to you. This 2D shear wave elastography, fibroscan, all these things you have to use it. Everything is available. I just used the help of some gastroenterologists, hepatologists. Send them in a proper referral stage, send them in a proper time of referral. If the patient is an F2F3 fibrosis, send them. If the patient is an F1 fibrosis, tell them everything about insulin resistance, insulin sensitivity. Just make them in a better state. Just give them lifestyle advice. Obviously, they will improve. And they will, one more thing is actually, they will improve the cardiovascular risk factors also. Ultimately, the insulin sensitivity improves. Even diabetes also will get improved. So there are so many things. So these are the targets for NASH: metabolic components, inflammatory components, apoptosis we have to prevent, fibrosis we have to prevent. So is there any role for last slides? Please bear with me. Last slide. Is there any role for bariatric surgery or endoscopic bariatric therapy? If your patient is having BMI more than 40, if your patient is having BMI more than 35 with a significant comorbidities like diabetes, dyslipidemia, or any hypothyroidism, PCOS, whatever things, significant comorbidities. If BMI more than 35 with the comorbidity, if BMI more than 40, there are use of bariatric surgery. Bariatric surgery, obviously, they will not go for. There are significant trials for endoscopic guided bariatric things only. Also, I am a advanced endoscopist. We are doing this endoscopic balloons like Orbera, Obalon. We can, these are all balloons. They will reduce the space in this one. There are some restrictive strategies like, just like a gastric bypass, there are some sleeves. We can put some gastric sleeves. We can put, have you heard about duodenal mucosal resection? They will ablate the duodenal mucosa. So there are so many trials which have been found out that actually duodenal mucosal resection will improve the insulin sensitivity. It will reduce the diabetes in some cases. HbA1c is significantly reduced, and this fibrosis also significantly improved. Duodenal mucosal resection is also there. this gastric balloons, bariatric therapies, then above all, pharmacotherapy, diet, exercise, behavioral modifications. I told you gastric balloon system, gastric emptying system, endoscopic gastric sleeve, gastroplasty, duodenal jejunal bypass sleeve. All these things are nowadays practical. Best thing is balloon. That is the having biggest data. All the things are recently approved, so significant trials are not there. So liver transplantation. When we have to do liver transplantation, NAFLD liver transplantation with the significant decompensation and MELD score more than 15. You have to go for liver transplantation, but what complication with the liver transplantation NAFLD thing is, because it is a metabolic component, obviously it can come again. So particularly we are using steroids, we are using immunosuppressants. There are chance of metabolic components by these drugs only. So over the time we have to do proper follow. Otherwise, NAFLD liver transplant, even after proper liver transplant also, they can come back. So nutrition is the biggest thing. So this is the NASH Day, June 12, International NASH Day. Join us to stop the epidemic. This is the biggest epidemic nowadays. Our era is facing actually so many people, even ours also. So I'm having grade 1 fatty liver. I'm not on treatment. I'm doing weight loss, whatever. It's not about practical. That adherence is difficult. Even for us doctors, it's difficult. But for we have to tell our patients adherence is important. Weight loss, body habit, this lifestyle modification, all these things we have to do. Thank you so much.
Thank you, sir.
Dr. Boni, that was actually an excellent talk. You have taken so much interest in pain to present us such an exhaustive presentation.
Thank you.
I think you have left us have not left anything to ask, I guess. But still, I'll see the chat box. I don't see any questions actually. Yeah, there is one question. May I ask you, are you okay with one or two questions? Is there any direct relationship between the duration of metabolic syndrome and NAFLD?
Yeah, madam. Actually, age, as you means we have seen in the slides that every this one FIB4, whatever AST, ALT score, whatever bad score, everything, age is a particular entity. Over the age means long-term diabetes, long-term metabolic dysfunction. Obviously, it will lead all particular NAFLD patients into steatosis stage, then fibrosis, and steatohepatitis stage. Over the time, they will go into fibrosis. We have to tell actually duration particularly important.
Yes. One question from my side, sir. Like, what is your personal experience with this saroglitazar?
Saroglitazar is a wonderful drug, man. Saroglitazar is a wonderful drug. Even steatosis also improvement. Even in NAS score also it is some. It's actually what is the treatment protocol? It is saying that actually over the 1 year,
yeah,
NAS score should improve by 2 points.
Okay.
And ALT should improve. ALT should be less than 17 by 6 months.
Okay.
Only saroglitazar have been shown that criteria.
Okay.
So other drugs are there in pipeline, but they didn't achieve the criteria. That's why they are not coming into picture. Only saroglitazar is there in diabetic dyslipidemia with fatty liver you can give. But with the help of one specialist, that will be better. First thing for one time, because any other comorbidity, because maybe this patient may be not just fatty liver, maybe some other association may be there. Just let them find out any other association. If it is there, just let them come back to you. Then just follow up the patient for saroglitazar. Just give them saroglitazar for 1 year. Then tell them just follow with the lifestyle modification. That's
Any
it.
frequently observed side effects with saroglitazar? Because once you read the side effect profile, you are a bit reluctant to give the drug. So have you come across some very frequently any side effects with saroglitazar?
Saroglitazar, I didn't find it. Means there are some side effects, obviously, some nausea, then gastrointestinal side effect. And particularly, this is a FGR agonist because intestinal lipogenesis. So intestinal lipogenesis, it will reduce severely, obviously. So obviously fat absorption, it will reduce. So some steatorrhea, diarrhea, obviously that will be there, but there is less percentage. But you can give, if significance is there, obviously you can send them to some specialist, obviously. Saroglitazar means advice.
And to see the improvement with saroglitazar, you need not do a rescan. You just have to see this
Ma'am, I
improvement
told
in
you,
ALT.
shear wave and fibroscan you can do.
Okay, fine.
After 6 months, that is better.
Okay, right.
There was one question from Dr. B.N. Khalida. How long can we give vitamin E?
Vitamin D actually it has to be given for 2 years. But it has to be in a non-diabetic patient.
Okay.
Diabetic patient, because P1 trial happened in non-diabetic patients. That's what. In diabetic patients, there is no trials. Even diabetic patients also you can give, but the thing is, there is no trial. I told you, even serotics, there is evidence, but no definite guidelines.
Yes. There's a comment from Dr. Vijayaraj that saroglitazar is a very underused drug. I feel that is very correct because even in affordable patients, we normally don't prescribe, or maybe, as you said, we should take an expert opinion before prescribing.
First, madam, take an expert opinion. Better thing, because
That's
maybe you may be labeling the patient for NASH. They may be taking this saroglitazar for some time. Some alternative component may be there. They may be coming with some other thing. That will be the problem. So other thing, see, the one young patient, maybe that may be a obese young adult because of some less mobility, maybe some obviously less activity. Maybe obviously it is very common for us to think this baby or this teenage person as just a NASH.
Yeah.
Maybe this patient may be exposed to some lipoproteinemia, lipoprotein disease, maybe some Wilson disease, we don't know. Or maybe hepatitis B, hepatitis C, whatever. There are so many guidelines. So just let them evaluate first, then let them come back. So that is the thing. That is the thing actually. That is the dilemma. So otherwise, okay. Saroglitazar or whatever, vitamin E, everything is advised. We'll just categorize this as a NASH. F2, F3 fibrosis. F3 fibrosis, ma'am, don't treat. Because F3 fibrosis, there is significant amount of patients. There is chance of portal hypertension. F3. So if the portal hypertension is there, there is actually some antifibrotic treatments, all these things. Let them treat. F2 fibrosis you can treat, madam. Actually, you can give vitamin E, whatever metabolic dysregulations, that this one, lifestyle modification, everything. Then you can. F2, you just categorize, just rule out all these things. Then fibroscan, 2D shear wave is better. 2D shear wave is available, do it. And just serum, I told you, AST, that FIB4, it is available online. It's just like a MELD score, a child score, it is free online. It's FIB4 and NFS score, that you can use it. And then treatment.
Actually, it is a very, very informative talk from you. And thank you so much for spending so much time with us. I think I'll hand it over to Aishwarya.
Thank you, sir. And thank you, ma'am. I invite Dr. Nigesh to give the vote of thanks.
Thank you, Aishwarya. Dr. Boni, that was a very fantastic talk. You have
Actually,
covered
it was exhaustive. I think everybody will vote.
No. Actually, what you have
very
observed
useful.
is that
Very useful.
very useful. And those who have joined in the initial time of the session, they have stayed till the end.
Yes.
It was very informative, very informative, and you have covered all the things. And actually, he's my friend, and it's good to see you again. And
even Dr. Prasad is my senior.
Bro, how are
and
you?
he's showing the same enthusiasm as a student to teach. He was a studious student that time, and he's showing the same enthusiasm to teach all.
No.
And he has
Actually,
taken so much
taking a
time.
big initiative. Actually, this is actually a wonderful thing. Actually, because it's actually not a disease. Because so many people are considering fatty liver is not a disease; it's a part of the disease, part of the lifestyle.
Yes.
So actually, they have to, because so many people are nowadays. Because I am working in a transplant center. So many people in some 30s, maybe they have a fatty liver. Now, actually, without any other thing, by 40s, they are coming as cirrhosis decompensation. We have to prevent this. Actually, this is just like hepatitis B, hepatitis C, because of our active intervention, almost it is getting eradicated. Now, this is the thing. NAFLD in NASH, we have to eradicate. We have to take this into limelight. We have to avoid all, because people are not aware. We have to take this into limelight, then we have to aware all the, even normal public, we have to aware. So otherwise now this 30, 40 lakhs, 50 lakhs, or maybe the lifestyle complications, they are going into cardiovascular factors. We can just let them leave the normal style. They are not considering
yes.
this as a disease. That's a problem.
Exactly. So a simple step by us can make their life better. Yes, that is a take-home message. And I once again I thank you, Dr. Moni, for this wonderful, exhaustive, A to Z presentation about NAFLD. And I also would like to thank Dr. Ropi ma'am. And with short notice, she has agreed to moderate this session. Thank you, ma'am. I also thank Dr. Prashobh, Dr. Aishwarya, and Dr. Vijay sir, and all other participants, those who have stayed till the end. Thank you, everyone. Good night.
Thank you so much. Thank you so much. Thank you, ma'am. Thank you. Thank you, Nigesh. Thank you, Prashaveda.
Thank you, everyone.
Okay, നിർത്താം അല്ലേ? നിർത്താം അല്ലേ?
പിന്നെ പെട്ടെന്ന് നിർത്തി വീട്ടിൽ പോയി ഭക്ഷണം കഴിയും.